Welcome to the stroke team. My name is Dr. Ivetts. I'm one of the two consultants that works on the stroke team. We very much welcome you to our firm and we hope that you have a really fun and educational experience while you're with us. Medically wise, there are two consultants, myself and Dr. Hedges. We have an SPR who's on rotation and we have a core medical trainee, a GP trainee, an F2 and an F1.
I'm Katrina Hedges. I'm one of the other consultants on our stroke unit. It's a 27-bedded ward. It's a busy ward. We're well staffed with nursing staff, other colleagues from the MDT, so physiotherapy, occupational therapy, speech and language, the dietitians, also very skilled nursing staff and healthcare assistants.
Much of the work of the stroke team is day-to-day ward-based care, looking after the patients that have had acute strokes, but also seeing them through their rehabilitation phase. We also run an in-hours stroke thrombolysis service, so that means often very rapid trips to the A&E department to consider patients for this treatment. We work very closely with our colleagues in radiology, neurology and cardiology, to name but a few.
My name's Tom. I am one of the core medical trainees at St Richard's and currently doing the stroke rotation. So the doctor's office is where we do the morning MDT board rounds each day. The safety huddle happens in front of the nurses station each morning as well. Our daily routine is we'll start in the doctor's office with the new patient's notes, reviewing the new patient's notes with the consultants, and then we'll do a ward round bay by bay and then finishing with the side rooms each day. We pause at 9 AM for a safety huddle on the ward, and then we go into a board round with all of our therapists and the nursing staff to run through day-to-day issues with each of the patients. We then continue with the ward round through the morning. Normally we finish that by about lunchtime, and then we will make sure we have lunch. That's always really important, to make sure that you're well fueled. In the afternoon it tends to be a mix of going through all the results from the morning ward round, anything that we've requested, a lot of meeting with families. We have a system where we book in appointments through the week, and often it can be that the therapists are better placed to update on particular progress than the medical staff, depending on the patients, just because of the intricacy of their problems and the level of disability that some people can be left with. Through the afternoon we'll also be checking blood results and preparing any tests that need to be requested for the next morning as well, so that they can be done in a prompt way, and hopefully then we'll finish roughly about on time.
We have a weekly Wednesday MDT at 12 o'clock, which we discuss patients in more detail, particularly those requiring complex discharges and those that have significant rehabilitation needs. We have an X-ray meeting at 1:15 every Thursday, which we meet jointly with our neurology and radiology colleagues, which is a very educational forum for discussing many of our patient scans.
The nature of the work is that at times we'll have acute admissions. We can have things such as an acute thrombolysis call, which would mean moving to A&E to see the patient and perform an acute assessment as to their eligibility for thrombolysis. And this is done with myself or Dr. Ivetts, medical staff and the nursing staff.
We're just down at the A&E department, which is one of the ways that patients come into the stroke ward. Behind me is resus, which is where we'll do the acute assessment of any patients who are eligible for thrombolysis. We get called down by a thrombolysis call, and we'll assess them in here before travelling to CT to do a scan of their head before bringing them back to resus to administer thrombolysis if they're eligible for it. So now we're in one of the CT scanning rooms. We've got two CT scanners on site at St Richard's. This is where we bring patients from resus to do a CT of their head to decide whether or not they're eligible for thrombolysis. Obviously we also scan most stroke patients' heads to establish whether or not there is an acute stroke visible on the CT scan. But in the hyperacute stroke period, we use this to rule out any bleeding to make sure that we can safely administer thrombolysis. The on-call rota is all part of the general medical on-call for the junior doctors. The registrar is on a separate rota from the SHOs, and the SHOs are on a separate rota from the F1. But the important things, I suppose, to be aware of are that If you're on the first on-call, then you'll be spending half your day on the emergency floor admitting new patients into the hospital. Whereas if you're on the second on-call, you'll be spending the whole day on the ward attending any emergency calls, but otherwise you only start your on-call shift actually at 5 p.m. in terms of the ward cover element. The SHOs are on call for 2 days at a time or a full weekend, whereas the F1 doctors will only do 1 day at a time, or the Saturday and Sunday but not the Friday. And the F1 doctors don't do nights, whereas all the other junior doctors do nights.
We are a very, very large team. In the fact that we work with a very large, as part of a large MDT, with many therapists and nurses and allied healthcare professionals.
As occupational therapists working on the stroke ward, we're all specialists in neurology. We work at looking at people's neurological deficits and how we can help people maximise their function following a stroke. Looking at sort of longer term rehab needs, short term rehab needs. Our main focus as an MDT is really to get the best out of our patients and help them reach their potential to make sure that they can go home safely, but also have the best quality of life that they can. In that, we need to do joint goal setting with everyone in the MDT and work very closely with doctors, nurses, physios, speech and language therapists and everyone to work towards the end goal of people going home.
Hello, my name's Julia and I'm the stroke specialist practitioner, and between myself and my colleague Janet, we cover the 120 bleep, which is the stroke bleep. So if you need to refer any patients that you suspect of having a stroke or have a known stroke in the hospital, please bleep us as soon as you know the patients in the hospital. We carry the bleep 9 to 5, and in that, when we're not carrying it, then the nurses on Lavant will hold the bleep, so you can still contact someone about stroke if you need to out of hours.
We work as educational and clinical supervisors for a lot of junior doctors across the trust and may have the possibility to provide that clinical support, additional clinical supervisory support for you while you're on our team.
There's a lot of learning opportunities on the ward, and they're not always immediately apparent, I think, when you start and are trying to find your feet in what's quite an involved ward environment. But from clerking in any new patients, whether they be thrombolysis calls or direct admissions to the ward, to having the opportunity for workplace-based assessments with the consultants on the consultant ward rounds. The fact that the consultants are there daily actually means that you do get pretty good exposure to them to be able to take an opportunity on a morning to ask to have an assessment at that time.
It is a busy ward because of the nature of the patients. They've often got complex medical but also social needs. There's a real element of acuteness to the work because obviously stroke is an acute medical condition. Thrombolysis is a hyperacute medical condition. So there's a lot of acuteness. There's also a lot of, for many of our patients who've been in a long time, there's often a lot of complex discharge planning work and meeting with relatives. There are also some difficult ethical issues about feeding. So it is a busy firm. The communication with relatives can be time consuming, but is a very, very important and valuable part of the work. But that is something that you will have real experience of working on this firm, as much as all the acute work in stroke that you will also be exposed to.
On the stroke ward, it's very different, and it can confront you with quite a lot of things that you haven't necessarily faced before, particularly in your F1 year. Decisions around feeding, working around end-of-life care as well. It can be a new experience, and you will be supported through that by the other members of the team, but it's a good opportunity to reflect on your experience of it, because you don't always see as much of that on other wards.
There's daily feedback on our ward rounds. We self-reflect on a lot of the cases and give instant feedback to the cases that are presented to us, that you will be presenting to us. There will be a lot of opportunity to clerk patients in, but also review clerkings of other people. So there's a lot of feedback that goes on a day-to-day basis at the ward rounds, but also specifically on the clinical ward rounds that we then go on to do every day.
Feedback's a really important thing because it helps you to understand what you're doing and how that's perceived by other people. And unless you ask for and receive feedback, you might not know that. So one of the things we're encouraging people to do is simply ask. When you're doing something on the ward, or whether you're with your consultant or your colleagues, you can ask them, would you mind when we're finished giving me some feedback? And most of the time people will do that. They'll say, yes, of course, I'd be happy to. But if you don't ask, it might not happen. And the other thing that's really important is sometimes it's important to give feedback. So the people that are teaching you might not really understand how you perceive them, how you feel they are. It really helps if you can say, would you mind if I gave you some feedback about how that went? Particularly if it's something good. If you give good feedback, it makes everyone feel better. It helps our morale, it helps engagement, so people really want to help you and you can help them. So just say, when we've finished, can I give you some feedback? And I'd be really surprised if they said no. If you need any help or you'd like some advice, I'm always available in the Trust to give that. So just ask if you can speak to Tony Miles, the leadership tutor, and I'll be able to help you with your feedback training.
Feedback is also feeding back to us during the placement, but also at the end of it, things that you've enjoyed, but also things that you would find more helpful. And we've really listened to that feedback over the years and have tried to implement change. So we're very receptive to feedback, not only from our patients and carers and the wider MDT, but very much from you as well. And we're very receptive to ideas to how to make stroke care better on the ward, and also what educational needs you think we could achieve better for you next time round.
For annual leave, all the annual leave is put through the rota coordinator for any requests to either change or to add any annual leave onto the rota. It has to be approved by your consultant as well before going to them, but then they'll approve whether or not it fits into the rota. They're pretty reasonable in terms of flexibility and adjusting things around to try and allow you leave when you want it, as long as everything is covered. In terms of study leave, I don't think you get study leave as an F1 still, but for the SHO and the registrar grades, you put in your study leave requests. Again, your consultant has to make sure that they sign the form, and then it goes, the best route is via the rota coordinator to make sure that they can cover any shifts that are necessary to be covered before coming over to the CMEC to be put in as study leave for any course reimbursement costs or anything like that.
Here at Western Sussex Hospitals, we have a team of dedicated pharmacists and technicians who serve the wards and provide our clinical pharmacy service. They will introduce themselves to you when you start with us, and they'll be your first point of contact for any pharmacy related or medicine related questions when you're on the wards.
Alongside the pharmacists, there's a large team of ward-based medicines management technicians who are based on the wards, and it's our job to take patient medication histories, counsel patients, check any medicines they bring in with them, report any problems or discrepancies to the pharmacists or medical staff, as well as making sure that anything that you prescribe is available for administration. Also, back at the pharmacy, there's a large team of pharmacists, technicians and assistants who are busy dispensing all the medication throughout the hospital and for outpatients. We also have 2 aseptics units at Worthing and St Richard's sites where we prepare chemotherapy for administration at both our hospitals.
We're always on hand to answer your in-depth clinical questions, but if there's anything that you need further advice, we have a really good team of medicines information pharmacists and technicians based here at Worthing Hospital, and the phone number of them can be found on the front of all ward-based BNFs. Here at the Trust, we have a dedicated medication safety officer, and her role is really for doing the prescribing assessments for the foundation trainees, and particularly providing other training around incidents and patient safety alerts that have happened nationally. One of the things is the prescribing of cytotoxic chemotherapy for cancer and non-cancer conditions, e.g. methotrexate. So for example, no foundation stage doctor should be prescribing methotrexate or any other cytotoxic agent for either a cancer or a non-cancer condition.
We've implemented electronic prescribings and a medicines administration system across the wards at our hospital, so when you start you'll be using electronic prescribing.
Here at the Trust we have some dedicated antimicrobial pharmacists. They're based across site, and their role is to really ensure that antibiotics are prescribed appropriately in accordance with the formulary and with national guidance. To help with this, there's an app that you can download for your phone free through the App Store. It's called the Micro Guide, or there's also a QR code based on our intranet that you can scan.
If you have any questions about medications or prescribing, just ask a member of the team and we'll be more than happy to help.
The stroke ward is a really dynamic ward to work on, and it's I found it. I've worked there a couple of times now. This is my second time of working on it, and I found it a very educational and supportive experience the first time around, and since then I can see that they've made changes, and I still find it to be a very supportive ward. The nursing staff are excellent and will support you when you need them to, and the consultants, they are always on the end of a phone if not able to come and be present on the ward to answer any questions and to support you in quite complicated decision making. I find that it's a very enjoyable ward to work on, I think.